Great. You made it. We are the last panel of the day. And I can't tell you how excited and happy we are to bring this topic to all of you, experts in interoperability across the country. Thank you, Marianne. Thank you, Brenda, wherever you are, for inviting us to do this today. We're going to start with a little audience participation. Raise your hand if you have had an immunization of any sort or a COVID test by your local pharmacist in the last 2 years. Check it out. It's probably 90%. You all are part of why we're having this conversation today, all right? Pharmacy, today we're going to talk about the primary care shortage, the role for pharmacists and pharmacy, and the needed role for interoperability to support this work. All right, with that, I am going to get started, and I'm going to have my incredible panel introduce themselves. Kevin, you want to start?
Thank you, Melanie, and it's a pleasure to be here today, and I want to thank everyone for sticking around for the last session today, as Melanie mentioned. This is my first time at the Sequoia Project, and I'm really excited to be here. I've learned a lot the past couple days. As Melanie said, I'm Kevin Nicholson, Vice President for Policy, Regulatory, and Legal Affairs for the National Association of Chain Drug Stores, NACDS. At NACDS, we represent most of the chain pharmacies in the country, about 40,000 individual pharmacy locations. And I'm really thrilled to be here because I've been with NACDS over 20 years, and I've been in the technology space even longer than that. So I've, and I've been active in NCPDP, been on the NCPDP board. So I'm really familiar with standards and policy, and one of my passions is advancing policies that connect patients to care at the pharmacy.
I'm Lisa Schwartz. I'm the Senior Director of Professional Affairs at the National Community Pharmacists Association. We represent the approximately 19,400 independent pharmacies in the country. Those companies may be single store owner, your sort of nostalgic mom and pop pharmacy, but we also have members that own 5, 10, 15, 20 members, so a little bit of overlap with Kevin at times. But one of my roles at the association is to make sure that pharmacists continue to be part of exchanging health information. We've been keeping electronic records for decades, primarily for the purpose of billing. And the pandemic really nudged or maybe shoved some people into providing some more standardized care services, and they found themselves needing to document those services. And sometimes even do some reporting. So making sure that pharmacies staying at the cutting edge where they have been for many years.
Great. Good afternoon, everyone. My name's Pooja Babbrah. I'm the pharmacy practice lead for Point of Care Partners. I'm the non-pharmacist on the panel, but I've been in the pharmacy industry for almost 30 years now. I was involved when we used to send out Palm Pilots to try to get doctors to e-prescribe even before SureScripts was around. So have been in the industry for a long time. You may be familiar with Point of Care Partners. My colleague Jocelyn Keegan is a program manager for Da Vinci. I work on the pharmacy side, but my background is also in standards policy and really the intersection of all that. I'm also on the NCPDP board, the prior chair, and was on the ONC. They had a high-tech task force that was focused on pharmacy interoperability and emerging therapies. And so we're going to talk a little bit about that today as well.
We are. Great, thank you, and thank you all for coming. I know when we asked, it's the time of year where it's tough, to consider whether you come or not based on budgets and all, and you all jumped at the opportunity to talk with all of you, so thank you. All right, so let's start out with a little discussion about the primary care shortage. Data shows, you probably all have seen this, there's lots of different data points. One I'll point to is, in the next decade, there's a projected shortage of about 139,000 physicians across the country. A large portion of that shortage is predicted to be in primary care. And it already is there. So at SureScripts, we thought, you know what, we've got like 2 million organizations and providers on the network in our directory. We can probably see this. So let's just take a look. And that's what we did. So we looked at the primary care, the broad definition of primary care across the country, and found that almost half of counties in the country have less than one primary care physician per 1,500 population. And what's more interesting even than that, that's compelling data, and there's plenty of other studies out there. This just happens to be what we see on the network. And when we take our pharmacy data and overlay that with this data, 2/3 of those counties have enough pharmacies in them so that it could make a difference if pharmacists take up some, not all, some of those kinds of primary care type things. And we'll talk about what those are. Some of this data is in data sheets you'll see on the tables here, and there's plenty of other opportunities to reference it. But when we saw this, we thought, there's something here. And so we know that primary care shortage is there. We know it's getting worse. We know that the projections are there and that there's an opportunity for pharmacy. Can you just talk a little bit about what you see in the marketplace right now for the opportunity, what's working, and where do you see it working? Start with you, Lisa.
So back in about 2016, NCPA partnered with another organization, Community Care of North Carolina, to start clinically integrated network of pharmacies. It's nationwide. The Community Pharmacy Enhanced Services Network, CPESN USA, is what that network is. It's about 3,500 pharmacies across the country that have the enhanced services means that they have a designated set of services that is above and beyond what many pharmacies offer beyond dispensing. So some of the minimums, everybody has to be offering immunization, they have to do medication synchronization, and I would emphasize that that's not automated refills. MedSync is calling the patient, making sure that they're ready for refills, finding out why they might not be if they're not. Sometimes that means that they've had a hospital admission, there's maybe been a change to medication, maybe they've had some side effects and they're just not feeling well, so they're not taking it. The pharmacist, or the pharmacist, and sometimes even a pharmacy intern, maximizing the staff that we have working in the pharmacy, can tease that out from the patients and figure out why a medication isn't working out for a patient. So medication management is a no-brainer. It's definitely well within the pharmacist's scope to be doing. We've seen states of pharmacy broadening some of what pharmacists are allowed to do, initiating therapies in certain circumstances. There are pharmacies in states that are allowed to initiate oral contraception now, to use point-of-care tests to initiate therapy based on the result of that test. Of course, primary care providers are going to be really interested in those sorts of encounters. Well, all of these pharmacies in CPESN USA are using Pharmacist Care Plan. They need to be documenting services. They're all using some sort of technology solution that's capable of producing that. It's HL7 Fire. With one exception, one company is doing CCDA, but for the most part, they're producing, it can go somewhere. Right now, it's just being used by the network as a quality assurance tool. But I'm sure that many of you are from companies or from provider organizations that would be really interested in getting that information from your community pharmacies. So that's one big thing that the NCPA has put a lot of time and energy behind in making sure that patients can access care.
Great. Yeah, and I'll just add to that. I think, when I saw this SureScripts data, I think it was eye-opening for me, and I kind of got on a little bit of a soapbox of why are we not utilizing pharmacists, right? There's so much that they can be doing, and we kind of came out of the pandemic with realizing, we all raised our hands, right? We've gone in and gotten our vaccinations. There's test and treat. There's other things that pharmacists can be doing. And especially in these rural areas, and I'll share a story, where I'm on the NCPDP board, and we're doing a lot around care coordination now. And the one thing that came up for us was, why aren't pharmacists getting ADT notifications when patients are getting discharged from the hospital? Today we send them to providers, we send them to long-term care facilities, but think about all those patients that are in rural areas where there isn't a provider there, right? And that pharmacist, if they got that ADT notification, could they be ready, right, with the medication? Could they be ready to do some of this, follow-up for the patient? And the story I want to share is, a dear friend of mine who's part of NCPDP knows how all this works, ended up in the hospital, got discharged, and she's in one of these rural areas, and they didn't have the medication that she needed when she got discharged from the hospital. And she hadn't even thought about, okay, I need to get it before I leave the hospital, and ended up not getting her medication for a week, ended up back in the hospital. So it's just a great example of, we are seeing this shortage of providers, and there's an opportunity for pharmacists to step up, but we need to give them the data and the way, to get notified, right, as patients are potentially getting out of the hospital. So ADT notifications for pharmacists is kind of my soapbox these days.
And building on what Lisa and Pooja have talked about, I just wanted to provide sort of a landscape of what we're seeing as far as federal and state policymakers, as far as what they have recognized pharmacists as, being qualified services that they are qualified to provide. And as Pooja mentioned, and as we all know, for better or for worse, the COVID-19 pandemic has showed us that pharmacists can provide these immunization and testing services. In addition, I'll just sort of run off a very high level of some of the services that are allowed in a number of the states. For example, pharmacists can order naloxone in all 50 states. Pharmacists can perform testing services in 43 states, and these testing services include diabetes, blood pressure, cholesterol. In 22 states, pharmacists can test and initiate treatment for flu, Helicobacter pylori, or strep A UTIs. Pharmacists can provide tobacco cessation services in 20 states. In 25 states and the District of Columbia, they can provide hormonal contraceptives under their own independent authority, and this is the prescription hormonal contraceptives. In 14 states, they can provide HIV, PrEP, and PEP. 4 states allow them to do TB testing. And then finally, immunizations. Pharmacists can, because of the PrEP Act, pharmacists are allowed to provide, and pharmacy technicians actually, are allowed to provide the COVID vaccine through the end of next year nationwide, irrespective of state laws. But then if you dig down a little bit more, as far as other vaccines, you see that pharmacists are able to provide the flu vaccine everywhere. Every state allows the flu vaccine. And 34 states allow pharmacists to provide the CDC ACIP recommended vaccines. So there has been pretty good progress in the states. A lot more work needs to be done. I would be happy if I could say 50 states were allowing all of these services, but a lot of work, a lot of progress has been made, and we are, as a pharmacist, it's very pleasing to be recognized as being qualified to provide these services. And actually, I almost forgot. The gold standard for all states is, believe it or not, Idaho. In Idaho, a pharmacist can provide services that can provide a service so long as it's treating a self-limiting condition, doesn't require diagnosis, is for an emergency, and there's one other criteria that escapes me at this moment, but the state of Idaho is pretty much, they've recognized that pharmacists don't need, very detailed protocols. They allow pharmacists to practice at the top of their qualifications, at the top of their profession, so long as, I know the fourth one was if it's a service that can be diagnosed with a test, such as strep or flu, something like that. So there are these 4 parameters, but within those 4 parameters, pharmacists can pretty much, if you go to your pharmacy and you have an emergency or you need a test, you can pretty much go to, in Idaho, you can pretty much go and have that performed for you. And I would add that even in Idaho and nationwide, 90% of Americans live within 5 miles of a pharmacy. So pharmacies are everywhere. We're in every community, both the independents and the chains. And we are very convenient. We're open nights, weekends, holidays. So, and we have less overhead. So we actually can provide services, a lot of these services more, at a better value to both the patient and the payer.
So there's an opportunity. The market, there's a market need for this with the shortage, right, in physician, primary care. There's law that says, in many cases, I hadn't heard you do that. That's more than I had expected, so that's good.
It's more than I expected, too. I just kind of kept going.
What's the challenge? There are many challenges to actually enabling all of this. So what are some of the challenges? Kevin or Lisa, you want to start?
Melanie, I won't deny the fact that there are challenges. Pharmacies, there are pharmacies, a lot of pharmacies are having troubles. You see pharmacists walking out from some of the pharmacies. You see pharmacies declaring bankruptcy. You see pharmacies, chain pharmacies closing stores in many locations. You see them limiting their hours. Right now there is a pharmacist shortage. And so I think what we're seeing, a big part of what we're seeing though, is sort of a growing pain as pharmacy is being challenged to move from a business model or a situation where they are seen as someone who's just providing medications, as some of my patients used to tell me back when I practiced in the olden days. All you're doing is taking medication. All you're doing is taking pills from one big bottle, and putting them in a small bottle. Why is it going to take so long? So that's kind of the view that pharmacists have had, I guess, over the to my dismay over the years. So we are seeing these growing pains as pharmacists are struggling, or they're being challenged to, provide the services that they are qualified to provide. Meanwhile, the prescriptions are still coming in, and that is a challenge. And we are at NACDS. We are working in the states to allow pharmacists to delegate more of the duties that don't require a pharmacist's expertise, allow them to be delegated to other pharmacy personnel.
Some of the same things are affecting community pharmacies, independent pharmacies. One of our members' biggest challenge is making the financials make sense. One of my new projects at the association has been taking over the financial digest that we put out every year. We survey members and we open up quite a bit of information, and we report it back to them. And the real juicy financials are something that we keep very, very close to the vest. But we have a public document too that talks about where revenues are heading, where profitability is heading for pharmacy. We do need to make sure that when pharmacies acquire products and dispense them, that they are paid fairly for them from health plans. Getting underwater reimbursements it happens often and is not acceptable. It is extremely hard to keep open a care site when reimbursements are making that impossible. But we are trying to figure out how some of the services that are now available to pharmacies are providing a revenue opportunity. One of the tangents from CPESN is a Flip the Pharmacy project. A lot of my members don't have the corporate office brain trust to work on business models that they can roll out through the entire company. So something like Flip the Pharmacy is very needed to help business owners, or somebody who's maybe managing one location of a small chain, to understand how their staffing model, how their workflow might need to be adjusted to make sure that they are successful when they add a service. Adding a service and then not expecting popularity or doing the right sorts of marketing, recruiting patients, that sort of thing, will lead to dissatisfaction and abandonment, and I think there's so much room for growth. We saw vaccines, obviously, during the pandemic get rolled out in a lot of pharmacies that maybe had dabbled a little bit, but then all of a sudden they were dealing with pretty high demand for at least a couple months. They had to figure out how to staff for that, do all the record keeping, and take care of their patients, and continue to fill all prescriptions at the same time. Obviously, we're an essential business, and we kept the doors open. I think similar to Kevin, you talked about some staffing issues. Our members are having trouble hiring pharmacists and technicians. We need people to work in pharmacies. Need to make sure that that's still a fun place to work, and part of that is finding out the right way to roll out a service. I went to pharmacy school. I wanted to take care of patients. I'm not interested in just working, a dispensing checking station. That would not be fun for me, and that's part of why I enjoy what I do. I'm trying to make sure that other pharmacists get to do the fun stuff. They get to own their own practice and take care of patients.
Yeah, just to add to that, I think this the whole payment thing, right, is an opportunity. And I think what we're starting to see now is, unfortunately, pharmacists still are getting paid to put the pills in the bottle, but there's opportunities for pharmacists and payers to work together. So we do a lot of work at Point of Care Partners, strategy work, and we've talked to a lot of health plans who are trying to figure out ways to work with pharmacists. And the biggest thing that we've heard through those projects are, how do we get the information to the pharmacist, right? And then how do they get the information back? So this sharing of information. And I think the couple things that we've heard is, first of all, they're faxing patient lists, right? Which just breaks my heart. But the systems are there. We all know that, right? And then the other thing is how does the pharmacist get the clinical information they need? And so we've been talking to a lot of health plans who are saying, we have all these things, programs we're trying to put in place to close gaps in care. And my point is, why not use pharmacists, right? I mean, we know providers are very busy. We know pharmacists can get into collaborative care agreements with providers to help with some of that. So how do we get those systems in place to share the information back and forth, especially the clinical information, the patient lists, and then of course, the whole payment, how do you get that reimbursement to the pharmacist so they're not just getting reimbursed for putting the pills in the bottle. But I think there's a huge opportunity right now for us, especially, given all the people in this room, to say, to think creatively, right, about how do you now pull pharmacists into the care team as well.
Yeah, it's funny, when I talk with some of you here about pharmacy, the thought is, well, pharmacy has got this, right? Like, electronic prescribing out of the gate, you're good. But it's not. What do you need with clinical interoperability? This is the need. So let's talk about clinical interoperability. Kevin, I know that NACDS did a whole study on this in the last year. You want to talk a little bit about that?
Sure. Thanks, Melanie. Actually, NACDS, we commissioned Levitt Partners to do a white paper on pharmacy interoperability, and Ryan Howells was one of those editors. I don't know if Ryan is here I don't see his hand going up, but Ryan Howells, who's here at the conference, was one of the one of the authors of that white paper. And actually, I have copies of the white paper if you're interested in taking a look at it. But it was a pretty comprehensive white paper that went through the challenges, a lot of the challenges that we're talking about, and provided recommendations for different stakeholders and how we can help solve this interoperability challenge for pharmacies. And the recommendations they made, I won't go into specific, all the specific details, but generally the recommendations that Levitt Partners made were at the federal level, at the state level, for pharmacies themselves, recommendations for the pharmacies themselves, recommendations for payers, recommendations for other healthcare providers, recommendations for technology companies, and some of the more interesting recommendations they made were, well, first of all, was the information blocking rule, and actually that was before this was written, before the rule came out. But recognizing that that implementation of that rule should help interoperability and thus help pharmacies become more connected and receive the clinical information that they need. Also, many of you may not be aware, but of all the different healthcare providers that are recognized as a provider in the federal Medicare program, pharmacists are not. Pharmacists have not been considered providers under Medicare. So for Medicare beneficiaries, pharmacists cannot provide services to that very large population. At the state level, recommendations include, providing coverage for pharmacist services in the Medicaid program. That Medicaid programs often have been known to do these pilot-like programs where they, the states are the workshops, are the laboratories, and in many cases, states could use their Medicaid programs to test the value of providing pharmacy services, of utilizing pharmacies to provide services to Medicaid beneficiaries. State HIEs, a lot of pharmacies rely on the state HIEs for clinical information, and there are ways to make those more robust, so they're bidirectional, and that they are easier for pharmacies to utilize. Pharmacies also use PDMP programs, and there are probably ways to make those more user-friendly, and to expand upon the medications that are included in the PDMP programs. And as far as pharmacies themselves, recommendations recognizing that pharmacies themselves need to invest in the technology, that they probably should be adopting cloud-based systems, and they should be looking to become FHIR-enabled. And a big challenge with the pharmacy community is that we live in the NCPDP world, and no one else does. So we're sort of like over here with doing our NCPDP thing, and everyone else is doing X12. So that's a challenge that pharmacies need to overcome in finding ways to crosswalk and provide that transaction, the ability to translate that transaction from one syntax to the other. Actually, and then some of the recommendations for payers, recognizing pharmacies as a healthcare destination that does provide value. We are more convenient. We can provide care at a lower overall cost, and recognizing, finally asking other healthcare providers to recognize, the value, and to consider, to recognize pharmacists as more than just people who put pills into bottles.
Let me show you a little data here. So we surveyed. It's not going. there it is. We surveyed about 500 prescribers and pharmacists to see what tools they need that would be most impactful in patient interactions. And you would expect prescribers to say access to clinical information electronically, but you got like almost 3/4 of pharmacists doing the same thing here, and on down the line. And so I want to turn it to Lisa. I think you've got a really great example of something I think you'll all find pretty interesting here. You want to talk about that?
Yeah, and I can tease out something that Kevin brought up too. So a little audience participation, or not if you don't want to.
Audience participation.
Oh, what the heck?
Oh, what the heck?
Well, I'm also realizing what I'm going to ask, and some people maybe not. Yeah. Anybody here have trouble finding Paxlovid once you had a prescription for it, or a loved one had a prescription for it? Got really hard to find. Part of that, so from my point of view, like one of the things that really hamstrung the test to treat program that HHS wanted to roll out in pharmacies was lack of provider status in the Medicare program. That meant that pharmacists could not get paid for a little evaluation and management appointment with the patient to see if they actually had COVID and actually they met the conditions under which a pharmacist could prescribe the medication. So lacking that, a lot of my members decided not to participate in the program. The dispensing fee that they were getting on dispensing the medication was $1 or $2. I heard as high as $6, whereas the publication that the NCPA Digest that I've just put out, the cost of dispensing medication is about $12.90. So we were asking pharmacies, both of our members across the country, to lose money on every Paxlovid prescription. Some folks did it anyway. They wanted to provide that service, and some of them saw it wasn't a reasonable business decision for them. So reimbursement aside, getting to Melanie's point, some of the conditions for pharmacists to be able to prescribe Paxlovid was having recent lab data for the patient's liver and kidney function, as well as a medication list to make sure that there weren't drug interactions. But we needed, the conditions were that if like some of that would be beyond the limited conditions that the emergency use authorization, the EUA, would allow pharmacists to prescribe the medication. So, like some of the issue was that, I know a pharmacist in Utah that was able to log into the HIE and log in, so you have to go into a portal to find out if there were labs for a certain patient, if they were recent enough, and if they meant that he could or could not initiate therapy for the patient. That even if it just takes him 2 minutes, that's 2 minutes too long, and get more proficient at it. But that's something that better exchange of information could eliminate that sort of thing. But that's just in one state. There are states that make it very difficult for pharmacists to get lab information that way. Sometimes we were relying on the patient to log into their portal and show us, here's my recent labs, and either was or wasn't okay, or they did or didn't have them, and they would have to be referred out from the pharmacy. The pharmacist didn't have the information that they needed to initiate therapy. Do you want to talk about that?
Yeah, I think that's a perfect example. So, ONC actually last November approved a task force to look at pharmacy interoperability. And so through the HITAC committee, we had about 5 months worth of work, and Dr. Stephen Lane was on there, and Anna McAllister, who you guys heard from earlier this week and yesterday, were on that task force with me and several other members. And one of the big stories that we shared for the task force, some of it was just kind of educating the ONC HITAC committee members on some of these issues. We were all kind of cheering like, great, now pharmacists can actually prescribe Paxlovid, but not realizing, right, that you had to have this lab value, and pharmacists don't always have access to that. So anyway, the task force, we just made our recommendations. They just got approved last week. We ended up with 32 recommendations, And this is the first time that ONC has actually looked at pharmacy interoperability. And so you can see this is becoming, a real kind of focus federally as well, to say, how do we make sure that pharmacists, if we are going to give them this ability to prescribe something, can get access to the data that they need. Out of the 32 recommendations, I think about half of them were about sharing clinical information. And so, the question becomes, in a public health emergency, and even beyond that, right? Like, how do we get the data that pharmacists need in order to provide care? There was a lot of discussion about how do you get pharmacists connected to HIEs? How do you share information? And, I already mentioned that two-way communication, right, between payers and, providers or providers and pharmacies. We just can't forget the pharmacists in all of this. And so I was really excited that ONC decided to put this task force in place. I grabbed Mickey yesterday and said, by the way, they're in your inbox, so what are we going to do about it? But I think you're going to start seeing, starting next year, some more focus, because a lot of our recommendations were, we need to pull more stakeholders together, right? It was great that there was a group of us that were on these calls weekly talking about this, but a lot of our recommendations were like, let's pull people together, whether it's to talk about, TEFCA, to talk about with HIEs, to talk about with payers. And TEFCA was one of the recommendations, right? Like, how do we get pharmacists looped into the discussions that are happening around interoperability? So,
right.
Some exciting work.
So a little more data. So remember, we're talking about pharmacists in a position to help with, a shortage in some areas. And so this is just, Kevin read off a whole bunch of things pharmacists are able to do. We can't see those on the network, but we can see prescribing. So, and by no means is prescribing, the only thing that pharmacists want to do or should do, but we can see prescribing trends. So we thought we'd look at them. And you can see the number of prescribers who are pharmacists on the network has increased quite a bit, still tiny. And the number of prescriptions that are from a pharmacist has increased, still tiny, really in proportion. The types of things that we see being prescribed are for diabetes, antithrombotic, drugs to treat psychiatric conditions like anxiety or ADHD, that kind of thing. And about probably 60% of those are in Washington State and California. In Washington, they actually have required since about 2016 or 17 that health plans include pharmacists in their network. And so that's part of what's making that possible there. But anyways, just some interesting data. When you think about all of this, I want to turn it back to all of you. When you think about this, you don't need all data, all clinical data, right? So how do you think about the clinical information that you need through interoperability to perform these kinds of services?
So, I think, especially where pharmacists are doing some medication management, there are some pretty obvious clinical parameters. You might need some of these INR if you're managing some anticoagulation therapy, A1C if you're managing diabetes medications. If you're looking, managing cholesterol medications, you're going to need to see their cholesterol labs. It's one thing to have the patient picking up their medications every month. It's another to know that they're having the effect on the lab work that they need to. And then if they're not, figuring out if it's the dose or if it's actually an adherence. I've heard stories from pharmacists that have patients that feel guilty for not taking the medications, and they want their pharmacist to like them, so they pick them up and they go in a shoebox. But I don't take them because they make me feel bad. But it's working through that. We try and help pharmacists with some motivational interviewing techniques to really figure that out. It doesn't matter if I like you or not. I want you to be healthy and to be getting the maximum benefit out of the prescriptions that you're buying from me. And we can figure that out together. So those are some of the laboratory data that we need. I think pharmacogenomic information is out there too. You have 100 and some drugs that have pharmacogenomic, like it's part of the indication.
Yeah.
But then I think there's so much more that we can learn about, drug selection and dosing and minimizing side effects when we have the information and know from the start with a patient how they're likely to respond to something based on this information. And that's hard to get. Medicare wouldn't cover the test ordered by a pharmacist. So in order for the pharmacist to get the lab data back, there's some collaborative practice that needs to happen, and sometimes that gets complicated, and there's a lot of admin work to get that set up. And it just would be so much easier if we were deemed providers.
Let me just open this up for a minute. We've got about 5 minutes left, and I do have one final question for this group, but I want to open it up to the audience for questions. Michael. Oh, they're running. I see. It's running, it's coming. Oh, whoops. Okay. Thank you.
This is not low.
It's not on.
It's not on.
Oh, turn it on.
Hello?
There you go.
There we go. Let me preface this by saying I'm a big believer in people being able to operate at the top of their license. Okay, so let's just start there. But the part I'm struggling with, well, there's a few things I'm struggling with. Yes, there's going to be a primary care shortage that's going to, in our face over, in the coming years when you look at physicians. But if we could deal with the scope of practice laws, or not laws, but regulations in this country, and allow nurse practitioners, advanced nurse practitioners more latitude, it seems like we could more quickly fill the primary care shortage than with respect and relying on pharmacists to do that. But that aside, I still see a role for the pharmacists. I mean, I see a very hybrid model here. It's not one or the other. But when I hear you talking about interoperability, it seems to me that's the least problem that you'd be dealing with. I mean, to get connected seems the easiest part. It seems like the real complicated part is dealing with the regulatory environment.
Yeah.
And the reimbursement. And because you even said, that, pharmacists, we're underwater for getting reimbursed for some of these things. If you can't solve the reimbursement, there's no business model.
No, we absolutely agree. I mean, as Melanie mentioned, all of us have mentioned that there are, there's the reimbursement challenges. There are the scope challenges. But I'm optimistic because, I've been with NACDS 20 years, and when I started, even 10 years ago, pharmacists weren't allowed to do perform many of these services, and I've seen it grow exponentially in just, the last 5 years or so. So I do see pharmacists being recognized more and more by policymakers, both federally and at the state, especially at the state level. But you're right. We do have challenges to overcome, but interoperability actually is a big challenge because we have our member pharmacies telling us that there are services that we like to provide, but we want to know. In many cases, just knowing that having the patient's full medication history is something that's needed. Knowing if there are any contraindications with other conditions that the patient is experiencing. So these are just so that is I guess interoperability. I mean, it's all of us, and I think. Pharmacy has sort of been like labs. Pharmacy sort of has been kind of like on the outskirts of it. But what we're here to say, we have challenges, but interoperability is happening, and we need to be at the table.
One more quick. Yep.
So Real quick, so Maryland, first of all, HIPAA includes pharmacists as providers.
Oh, correct.
Covered it.
So shame on Medicare, sorry if I'm offending.
Thank you.
They don't recognize it. Second of all, North Carolina has a whole care management pharmacy program that's been working
They do.
tremendously. And then my question is, because I did a pilot with a specialty pharmacy, and I don't know if that's part of your calculus, and, and in Maryland, if the pharmacist submits their list of patients, then they can get the push on changes, push on them going to the hospital, and they're included in the exchanges through CRISP, as long as they're signed up for that. So
Good.
I think there are models, and and then it seems to me the challenge is how do you get a broader adoption and embracing of working models, and the demonstration that pharmacists have a huge role to play, especially because medication management drives enormous costs in the system, and that's been proven over and over again. So I think you guys should be taking off, not
Great comment.
pushback.
Great, thank you. And actually, I just want to say that at NACDS we have been active in a number of the states that have implemented HIEs, and I believe that Maryland is one of the states that we consider to be a state that has done a really good job.
Great. All right. Well, one last question for this group, and I have to just say we completely agree. This is payment policy followed by product and technology, and the key here is it's a dance. And so keeping the technology up in front so that it's there as you need it, because you need it already and you're going to need it more, right? So that's the key. So you have this incredible group of interoperability experts in front of you. What would you like them to remember and take away, call to action? Pooja.
So I would love to see a work group. You guys are talking about all the new work groups you guys are doing. I feel like the work that we did at ONC, if you do go out and read the recommendations, it's all about continuing the discussion, right? We are just starting to talk about pharmacy interoperability. And I always laugh because, we talk about pharmacy interoperability and people are like, oh, you guys already do that, right? You're already doing prior auth electronically. You're already doing this, but what we need, and what you heard, I think, today is as we move pharmacists forward and we start to see some of these, reimbursement models be out there, how do you get that clinical information? And let's get pharmacists to the table. So my ask would be, let's start a pharmacy work group here at Sequoia. So I think that would be my ask.
Lisa, we got like 30 seconds.
Okay, I would keep it front of mind that pharmacists are part of the care team. I think the care plan is a really cool. I was trying to what's the right sports analogy here? Is it a really good racket or a really good ball that we want to get everybody? We want to bring it to the game and take care of patients. Quick.
Kevin.
Well, I would say if you are a QHIN candidate, or if you end up becoming a QHIN, please recognize pharmacies and help pharmacies come to the table and become involved in in the QHIN and in the exchange of information. It's sort of a plea to help us help you.
Great. All right. Well, thank you very much.
Thank you.
All right.